Hello, everyone, and good afternoon. Thank you so much for joining this month's Fireside Chat in honor of Glioblastoma Awareness Day. This day is dedicated to shedding light on this aggressive and rapidly growing brain cancer. Glioblastoma affects thousands of lives each year, and through events like this, we aim to raise awareness with hopes of advancing research towards finding a cure. So the Fireside Chats are brought to you by the Office of Community Outreach and Engagement at the Masonic Cancer Center at the University of Minnesota. The Office of Community Outreach and Engagement serves as a bridge between the Cancer Center and communities across the state of Minnesota and beyond. Our team's mission is to reduce the burden of cancer by engaging communities and providing them access to knowledge and information on the latest cancer research, cancer prevention, the importance of screening and early detection, treatment options, survivorship, as well as clinical research opportunities. My name is Amna Hussein. I am the Community Engagement Coordinator on our team, and on behalf of our team, thank you all so much for joining us today. As mentioned earlier, today we observe Glioblastoma Awareness Day. Glioblastoma is the most common malignant brain tumor in adults. Its aggressive nature and resistance to treatment poses significant challenges for patients and their families. This is why on the third Wednesday of July, every year, Glioblastoma Awareness Day is celebrated. It serves as a platform to educate the public about this devastating disease and rally support for improved treatments and outcomes. Today, we are joined by Dr. Andrew Venteicher. Dr. Venteicher is a neurosurgeon, a UMN researcher, assistant professor, and is the neurosurgical director of the Center for Skull-Base and Pituitary Surgery, which focuses on diagnosis and comprehensive treatment for patients with tumors along the base of the brain, pituitary gland, and the brainstem. On the research side, Dr. Venteicher is part of a new translational research initiative between the University of Minnesota's Medical School and the Masonic Cancer Center that is exploring the genomics of brain tumors. Dr. Venteicher earned his BA from the University of Pennsylvania in mathematics, biochemistry, and economics, as well as an MS in chemistry. He attended Stanford for both his medical degree and his PhD in biophysics. He trained at Harvard Medical School for his residency and was selected for a prestigious cerebrovascular and cranial-based fellowship at the University of Pittsburgh. The Minnesota Monthly Magazine named Dr. Venteicher as a top doctor in 2021 and 2022. He is incredible, and we are so honored to have such a renowned expert in the field of brain tumors joining us today. Dr. Venteicher will provide us with an overview of brain tumors with a focus on glioblastoma, exploring its causes, its prevalence, the current treatment options, and then he will also be sharing some valuable insights from his recent publication, which sheds light on racial disparities in surgical recommendations for patients with brain tumors. So we will be recording today's Fireside Chat, and you can refer back to the recording on the Masonic Cancer Center's public YouTube page. Before we begin, I would like our audience to get familiar with using the Q&A feature, which is going to be located on the bottom right of your Zoom window. During Dr. Venteicher's presentation, please use the Q&A feature to submit your comments, questions, and reactions. For University of Minnesota employees and spouses participating in the University Employees Wellbeing Program, I'm going to put a link in the chat shortly for you to mark your attendance to earn your wellbeing points today. All right, without further ado, Dr. Venteicher, the floor is all yours.
Okay, well, thank you, Amna. I'm going to share my screen here. All right. Can you see that?
Yes, all good.
All right. Well, thank you for the invitation. It's a pleasure to be with you today. I was asked to give an overview of brain tumors with an emphasis on glioblastoma in light of Glioblastoma Awareness Day. As Anya said, I am a neurosurgeon here at the university, and I focus on skull-base tumors. That's largely tumors that affect the brainstem, skull base, pituitary gland. And we also, in addition to the clinical practice, have a clinical research program and scientific research programs here at the university focusing on brain tumors. And that experience will frame a bit of our discussion today. So look forward to speaking with you, and happy to discuss as we go through. Okay, so what we'll discuss today is what I thought we'd do is review the most common brain tumor types, and we'll just focus on three. We'll focus on the most common tumor that affects the brain, the most common primary benign tumor that affects the brain, the most common primary malignant tumor, glioblastoma, that affects the brain. And we'll talk about the demographics and background of these, but we'll also highlight a couple of themes that emerge as we move through some of the research that's being done on these. And I think one of the overarching messages that I think about when I think about the developments that have recently been applied to brain tumors is that we're finding tumor subtypes that are clinically meaningful. And I think that's been a very important step forward, and I'll show you some examples of that. Because as we find new subtypes for these variety of tumors, we're finding new treatments. And then finally, I'll show you a little bit of the data that I was asked to show about a recent publication that we had, just focusing on the role of surgery and how we implement that in the clinic. Because surgery is one of the first-line treatments for most of these primary brain tumors that we see in patients. And when we say the term brain tumor, what do we really mean? People will lump a lot of things into the category of brain tumors, and it's a very diverse group of tumors. So really what people mean, they tend to mean intracranial, so things within the skull. And it turns out when you categorize all of those tumors, over half, about 50 to 70%, are metastases, or so-called secondary tumors. These are tumors that started, or cancers that started elsewhere and found their way to the brain. And just under half, about 30 to 50%, are tumors that arise from the brain or central nervous system and its supportive tissue. So again, we'll talk about the top three that come from a variety of categories related to this. And a common question that we're asked is, what symptoms do you expect when one has a brain tumor? And there are general symptoms that are just not very specific, but when we think about a brain tumor, many people think of, which are like things like headaches or nausea. But the other symptoms may reflect parts of the brain, depending on the location that's affected by the tumor. So for those of you less familiar, I'll just highlight a couple of the general territories in the brain. So the frontal lobe, the largest part of the kind of cerebrum, the top part of the brain here, controls executive functioning. These high-level functioning. Parts of our personality are framed in the frontal lobe. A significant component of language in terms of expressive language, the ability to deliver language, is encoded largely in the frontal lobe. And the very back aspect of the frontal lobe is the motor area. So that is, movement is encoded in the frontal lobe here. So it's a large territory that's expanded in humans to carry out these functions. Behind that is the parietal lobe. This is where sensation is encoded. So the ability to feel touch, pain, and your joint space. The larger territory of the parietal lobe also helps with spatial awareness, where things are in three-dimensional world. And they also helps us to recognize parts of the world, or to see faces, or recognize music, etc. So it's a very complex set of tasks that are integrated in the parietal lobe to carry out those functions. So tumors that affect these lobes can affect these functions in humans. The very back of the brain, the occipital lobe, encodes a large territory of the brain is devoted to that, because that's where vision and our visual fields and our visual acuity is encoded. And then off to the sides of our brain is the temporal lobe here. And the temporal lobe, the deeper structures of the temporal lobe encode memory and emotion. Another component of language is encoded here. The ability to understand, or receptive language, is encoded here. And then hearing integration is an important task carried out by the temporal lobe as well. The back of the brain here is a very old component of the brain evolutionarily, but it actually contains a majority of our neurons. And the reason for that is it fine-tunes our movements and provides a significant amount of function in terms of our balance and coordinating complex movements and tasks like walking, etc. So a significant component of the neurons are contained in the cerebellum. something on the order of 70 billion neurons in the cerebellum to carry out those tasks, with additional functions carried out supratentorially. In the front of the brain, here is the brain stem. And that's, of course, close to my heart, where I see a lot of patients with lesions in and around that area. And this is a highway where many tasks are integrated and signals are sent from the brain down into the spinal cord. It also encodes a lot of cranial nerves that carry out functions in the head and neck, such as facial sensation and facial movement, hearing, taste, etc. So depending on where a tumor is affected, you might get symptoms in any one of these areas. So with that as a backdrop, I thought we'd talk about the most common tumor that's found in the brain, which again are secondary tumors. These are cancers that begin elsewhere and spread to the brain. This is one example of an MRI from a patient that has brain metastases. And this poses a significant problem in cancer patients for a variety of reasons. Approximately 1/4 of patients will develop brain metastases, and this is 1/4 of cancer patients, all comers. And we've known for some time that certain cancers have a higher propensity to travel to the brain, and the mechanisms by which this happens are incompletely understood, but an area of intense study so that we can take advantage of these therapeutically. And I'll show you a couple examples of how we're beginning to understand this process. And some of the more common brain metastases are shown here. Not all brain or cancers that arise elsewhere contribute equally to the development of brain metastases. There's a great bias in which ones cause brain metastases, all comers. And you'll see in this pie chart here that lung cancers make up the vast majority of brain metastases, just because lung cancer is fairly prevalent and it has a particular tropism to make it to the brain and have it survive as solitary metastases or multiple metastases that can be present. Other cancers that like to travel to the brain include breast cancer in women, melanoma, which is increasing in incidence, cancers of the GI tract, as well as kidney cancers. And then there's rarer cancers that also can travel to the brain as well. And importantly, as our drugs improve for systemic disease control, which has been a dramatic I would say success story in the last couple decades with a specific number of cancers, we're seeing that there's an increased incidence of brain metastases, all comers. So this is an important focus of research to understand this process. And even within those broad categories of cancer types, there are particular subtypes of cancer that have a tendency to travel to the brain. So for example, in breast cancer, there are 4 general subtypes of breast cancer based on the presence of 2 receptors. Hormone receptor, which itself is 2 types of receptors, and HER2, which is another type of receptor. And whether you don't express any of them or express HER2 or just the hormone receptor, you can subcategorize breast cancers into these 4 different subgroups. And this has been used clinically to help guide treatment. And we've known for some time that based on the breast cancer subtype, there's a different propensity to develop a brain metastasis. So for those breast cancers that have HER2 positivity or triple negative, they contribute to brain metastases in over 20% of those patients, whereas those that are just hormone receptor positive but don't express HER2 and they're not triple negative, those are less than 15% will develop brain metastases. So that actually changes our clinical management for how we will follow these patients. And heterogeneity in tumor types also applies to other cancers, including melanoma. So I thought I'd show you an example here of melanoma because the systemic treatments have really improved our ability to control this tumor in the body. And that's contributed largely to our increasing incidence of seeing brain metastases from melanoma in the brain. And the new systemic treatments that have been available for melanoma, not too much to get into the details, but just to show you an example here, arise from our increasing molecular understanding of several of these cancers, including melanoma, which is shown here. So over the last decade, there's been a great emphasis on genomics, that is genetic sequencing and other molecular testing for cancers to try to subdivide them in clinically meaningful subgroups. This is, again, a theme that will come up over and over again in the slides today. So for melanoma, we know that there are different mutations in genes that will give rise to certain subtypes of melanoma. And for example, over half of melanoma will have a mutation in a gene called BRAF, and it happens to be the same mutation that just in the last decade, folks have developed inhibitors to this mutation, and those inhibitors are very successful in extending survival and progression-free survival in these patients. Also, fairly new to the scene is the development of immunotherapy that is using medications to help train your immune system to recognize the tumor as foreign so that your own body can attack the tumor. And that has now been applied to melanoma and many other cancers very successfully, not yet to brain cancer, which we'll get to, but to other tumors in the body. And that has also contributed to the ability to see patients do better and have a longer time of survival where they'll develop brain metastases more commonly. So for example, survival from metastatic melanoma has increased from 25% back before these drugs were available and other drugs like it, up to now 85%, which is quite good. And we know that now brain metastases are expected to occur in over 50% of patients with metastatic melanoma. So back more in a translational research focus, we're very interested in understanding this as a community, how cancer cells that start elsewhere happen to get into the brain and contribute to a metastasis successfully. Well, it's a new environment. The brain tissue itself is a new environment, which, as many of you know, is protected by the blood-brain barrier. And many molecules and cells are excluded from the blood-brain barrier from a series of mechanisms. And there's a constant editing that happens in the brain tissue. So we've now seen in other groups have studied this where cancer cells can try to take hold in the brain, but they're constantly edited out by resident cells in the brain, for example, reactive astrocytes. And these cells will actively secrete proteins that can kill cancer cells. And if cancer cells didn't evolve, that would permanently keep cancer cells from growing in the brain, but it turns out cancer cells do evolve. And they've found ways when they can generate a successful metastasis of inhibiting the process by which they're edited so that they can create a brain metastasis. So there's a constant battle, if you will, between the resident cells in the brain and cancer cells in the body in trying to kind of combat this process of cancer cells creating metastases in the brain. This tumor evolution is an area of active focus because once cancer cells can get by this process, they can take hold and they're now within that blood-brain barrier and may not be seeing those systemic chemotherapies that are delivered to the body because those are typically excluded from the brain environment. So they can be a little protected in the brain environment as well. So we're trying to understand that process so we can try to take advantage of that therapeutically. Now, while tumor evolution is important, it turns out that sometimes it can be taken advantage of. So this was a very interesting study done where, and it was a genetic study where they took a look at patients that had a tumor in an area of the body, for example, breast cancer, lung cancer, ovarian cancer, which is this patient here. And they took a look at the mutations that occurred in the primary tumor, in this case, an ovarian tumor. And they looked at that same patient's brain metastasis. This patient happened to develop a brain metastasis that needed surgery. It was removed and all the mutations cataloged there. And it turned out that sometimes tumor cells evolve in ways to make them more likely to develop brain metastases, but it also exposes new vulnerabilities. And this was one example of that, where they found that this patient developed an amplification, so an increased expression of a protein for which we have a drug for. And this is ERB2, which of course is HER2, where we have an antibody available to that can be used therapeutically. So sometimes we take a look at how tumors evolve in the brain in order to take advantage of that process therapeutically. Now, while most cancers are secondary, that is, they arise elsewhere and then travel to the brain to develop a brain metastasis, there are a great variety of primary tumors, that is, tumors that arise from the brain tissue or its supporting structures. And this is just a cartoon of several of the common examples here. The most common one is meningioma. These are tumors that arise from the meninges. Other examples include gliomas. These are tumors that arise from brain tissue itself, thought to be neuron and glial precursor cells or stem cells. Another common tumor in the brain are tumors that arise from the pituitary gland, for example, pituitary adenomas or craniopharyngiomas or Rathke cysts. The cerebellum has a tropism to develop other types of tumors, other types of gliomas, ependymomas, medulloblastomas, and the brainstem itself can develop gliomas as well as schwannomas, which are tumors that arise from the cranial nerve sheaths, the surrounding structures of the nerves that arise from the brainstem. And all told, this is a fairly big cause of neurologic morbidity and a reason that a lot of patients will present with these issues. In the United States, the prevalence is about 25 per 100,000, and that's a decent number. That means almost 100,000 new diagnoses a year in the United States alone. And primary brain tumors as a class affect patients of all ages. And in fact, in the pediatric population here, 0 to 14 years, it's the #1 incident tumor in the brain and central nervous system. It drops to the #2, but still highly prevalent in older children and young adults. And then in adults 40 years and older, it's still a fairly common problem, ranked here behind melanoma. But you'll see here that the incidence is still 44, which is per 100,000, which is more than we see in the younger individuals as well. This type of data has really been useful in trying to catalog what types of cancer, whether they be in the brain or elsewhere, by using databases such as the CB Trust, which catalogs the brain tumors over 5-year epochs so that we can study the epidemiology like this. So that's a resource that's updated every 5 years. Also from the CB Trust, we know that brain tumors as a class comprise both malignant and benign neoplasms. So that's listed here. And when we think about brain tumors, most will immediately think about glioblastoma, which is the most famous, as that is the most common malignant tumor. And that constitutes about 15% or 14 or 15% in this slice of the pie here. But it's important that to point out that actually most of the tumors found in the brain that are primary are actually benign. That includes meningioma, which is about 40%, pituitary tumors, which is about 17%, schwannomas, about 1 in 12 or 8%. And then, of course, the most common malignant tumor, glioblastoma, almost 15% of these are that. So as you can see, there's a range of brain tumors that arise from various types of supportive tissues or the brain tissue itself. They have varied pathology, the appearance on them, which is the way they're diagnosed. They have a variety of clinical behaviors, and they have different molecular underpinnings, which we're understanding more and more every year. And that obviously is a very exciting area of research that is framing how we might treat these in the upcoming decades. And it's kind of funny to think about which tumors arise by gender. Unfortunately, this doesn't work out well for males, but many of the malignant tumors in the brain have a slightly higher incidence to occur in males. So it's many of the gliomas that we talked about, including glioblastoma. It's a slight prevalence, a higher prevalence in males, but it certainly happens in a good number of females as well. But you'll note that the benign tumors, the most common ones, including pituitary tumors and meningiomas, are more likely to happen in women, which is off to the left side of this graph here. So the next thing, we'll just talk briefly about some of the research being done in meningiomas, the most common benign tumor. So some background on meningiomas. This is the most common primary tumor in the brain. Meningiomas, as they sound, arise from the meninges, which is the coating that protects the brain and contains all the cerebrospinal fluid, which keeps the nutrients towards the brain tissue itself. It accounts for about 40% of the primary intracranial tumors that exist. It arises from the meninges. It comes generally in 3 grades. The overwhelming majority of these are benign or grade 1 or 2. There's only a few percent that are grade 3, and we consider them more on the malignant end of the spectrum because they grow more rapidly and they sometimes spread to other areas of the meninges. The standard of care for these tumors is either, when they require treatment, surgery or radiation, but we don't yet have a good targeted therapy or chemotherapy agent that is considered a useful strategy for these tumors yet, although clinical trials are emerging, including at our institution here. So when we think about treatment for meningiomas, surgery is an important one. And this is, as a surgeon, how we think about how we're going to do a surgery here. We want to get as complete a resection as possible because that's associated with the decreased rate of recurrence. And that's shown here. So a Simpson scale is kind of how we think about resection of meningiomas. If we can get them all with their base, the recurrence rate's the lowest, it's about 9% over 10 years. But if you get less of the tumor or a subtotal resection, that recurrence rate can be a lot higher. But what we really like to do is understand different types of meningiomas in more subtle ways. And what I mean by that is we don't yet have great biomarkers for aggressiveness. We treat meningiomas largely as a single group, aside from trying to subdivide them by grade, which is pretty useful. But we'd love to know exactly how to predict which tumors are going to grow or recur much more rapidly than others so that we can design better treatments for our patients. And some of the progress has been fairly exciting on meningiomas over the last decade, and this is one example shown here. So I showed you something similar to this for melanoma, where the mutations that are cataloged in different types of meningiomas have now been discovered. And it was previously thought that most meningiomas, or the overwhelming majority, arose from mutations in a gene called NF2, or neurofibromatosis 2. But we're now understanding that meningiomas that arise from other areas in the brain or other areas of the skull base, as shown here, have a propensity to develop new mutations in other genes and not NF2. And the hope was that the understanding of these mutations could help us predict which patients would do better or worse so that we could come up with a molecular test to help predict that. It hasn't been that simple with the genetic mutations that arise in meningiomas. It doesn't quite correlate with grade as we hoped, but it's still a very useful strategy that may be useful in the future in designing chemotherapies. But aside, our parallel research angle had looked at other areas, not just DNA mutations that occur in tumors, but also other areas of genomics of meningiomas that help predict survival much more meaningfully. So it turns out that there were 3 different studies over the last 5 or 6 years that use a series of different molecular testing that were able to predict how patients do. And it's not important to dive into the details of how these were done. They're fairly complex applications of genomics. But the point is that each of these groups were able to come up with molecular strategies by which to predict which patients would do worse, which patients would do far better. And this could help us in understanding which patients may need adjuvant therapies in addition to a surgery. And this, we anticipate, will kind of be the diving board by which to design clinical trials in the future to predict which patients will do worse and may need additional therapies. And to do that, we're constantly looking for new biomarkers by which to risk stratify patients. So these studies over the last decade have come up with really interesting markers that have in some cases been used clinically. So this is one example where you take all of that genomic data and you come down with a single gene test, for example, a telomerase promoter mutation, and that can predict which patients will do well. And if you have the mutation, which patients will do poorly, and these patients may need additional therapies. And that has been actually already useful in the clinic. So we do these tests routinely for meningiomas when we think that they're on the more aggressive side to determine which patients may need closer observation or additional areas of or additional therapies. And finally, this is more in the hypothetical stage, but we're using this type of knowledge to try to understand whether we can take advantage of the molecular subtype of meningioma and come up with new therapeutic strategies that may not treat all meningiomas, but just one of the 4 subtypes or one of the however many subtypes of meningiomas much more successfully. So designing clinical trials based on the molecular understanding is a general theme across cancers, including tumors in the brain. So we'll spend the rest of the time talking about glioblastoma in honor of Glioblastoma Awareness Day. And glioblastoma, again, is the most common primary cancer in the brain. It arises from the brain tissue. It's thought to be a neural stem cell or something like it that arises from which these tumors arise. They're very well known to be aggressive. It accounts for about 17,000 new diagnoses in the US annually. And again, surgery is the first line, but we know that it won't be curative. And the reason for that is this. I wanted to show this study here, which kind of highlights one of the key challenges with glioblastoma. So what this study did is it looked at a patient with glioblastoma. So this is an example of the MRI where we see an abnormality here on the left side of the brain. We also see a smaller abnormality just off to the right side of the brain. And took a look at that patient's brain tissue after they passed away. And they sampled different areas of the brain to look whether there were actually cancer cells in areas that were not highlighted on the MRI. So it's obvious where the tumor was, the bulk tissue anyway, but even in the other side, in the temporal lobe, where there was no obvious tumor on MRI, you can find presence of cancer cells using detection techniques that we don't need to go into. But this has led to the notion that glioblastoma, by the time it's diagnosed, sometimes has already spread to other areas of the brain that might not be evident on an MRI. So as a surgeon, we might be able to take out what is obvious on the MRI, but we have to acknowledge that there may be lingering cells in other areas of the brain that we don't want to resect because we don't know how to target that. And that would be the target of additional types of therapy, ideally some type of medical therapy that could target those cells in other areas without the need for a surgery. That's one of the principal problems. And the standard of care for treatment of glioblastoma is surgery, followed by chemotherapy and radiation over the course of 6 weeks. And that has been shown to improve progression-free and overall survival. And this is one of the landmark studies by Stoop et al. That was published in the New England Journal of Medicine in 2005. And what it showed is that if you just give patients surgery followed by radiotherapy alone, they have a overall survival, a median survival of about 12 months. But if you add this chemotherapeutic agent, temozolomide, you can extend survival to about 14.6 months. And this difference in overall survival led to this surgery followed by temozolomide plus radiotherapy being the standard of care. And one thing that in hindsight we now acknowledge is that it's been interesting to know in studies like this that there was not, in ways that were not yet understood at the time, why some patients did much better. And there's these tales of patients that would survive for longer amounts of time, over 3 years, for reasons that we didn't understand. They tended to be younger, but other than that, there wasn't a great molecular test by which we could figure out which patients would apply in these groups. And it turned out that over the next couple of years, genomics and genetic sequencing came on the scene and taught us that gliomas are not all the same. So just a few years later in Science, a paper was published where they took a look at all aggressive gliomas and they did sequencing, and they found that a subset, about 12% in the series, had mutations in the same gene, IDH1, or its related gene, IDH2. And it was a same mutation that happened in the same area of the protein. And that was a clue that that was a very important mutation that somehow contributed to the tumorigenesis, the aggressive nature of this type of tumor compared to its non-mutated counterparts. And when they looked at how patients did in these two different groups, the ones that had the mutation versus them that didn't, it turned out that the ones that had the mutation was a fundamentally different subtype of cancer, because those patients did far better than those that lacked the mutation. So in the patients that lacked the mutation, the survival was just over a year, but in patients that had the mutation, it was over 3 years, and in some cases, we now know over a decade or longer. And again, the patients that had the mutation were younger. So this was a potential explanation for why in that previous study, some patients did far better in both of those treatment arms, because maybe those patients were more likely to have IDH mutated tumors, which is now we understand a different fundamental cancer altogether. And it turned out that IDH status is very important. We now test all gliomas for IDH mutation now. So just after its discovery in 2008, it just took a few years for that to make immediate impact in large academic centers like here. And it's now used universally across all centers that do surgery for gliomas to test those tumors. And the reason for that is IDH status predicts survival much better than grade did, which was the histopathologic criteria by which we could call a tumor more or less aggressive. So this molecular understanding of tumors rapidly improved our ability to predict how patients would do. And it did it so rapidly, in fact, that the guidelines by which pathologists will diagnose a glioma now have fundamentally changed from that of just looking at how a tumor appears under the microscope to now include this type of molecular testing. So we now diagnose patients based on a combination of how the tumor appears histopathologically, but also its genetic mutation in IDH. And that's shown here. And the reason for that is it just does such a good job at predicting which patients will need additional therapies and which patients will be expected to have a longer survival. Just to, I think when we think about brain cancer in general, a common thing that we hear is that there's not been a lot of success over the last several decades. And I just wanted to highlight a very recent paper that just came out last month regarding the IDH mutated tumors. These, again, are the younger patients that tend to do better. There's a recent development that now shows that we have our first targeted therapy for this class of gliomas, and it's led to some excitement in the field. And this is a recent paper just shown in the New England Journal, taking advantage of this identification of the IDH mutated tumors, where they've now come up with a drug that can inhibit the mutated IDH, and patients on the drug do far better than the patients that are not given that drug. So this was, when I think back about the progress in the field, it was 2008 where the discovery of the IDH mutation had occurred to predict that which patients might do better. It was then 8 years after that where our diagnostic criteria changed, by which every glioma now gets tested for IDH, to then 15 years after the initial discovery, by which we now have a drug therapy that's proven in clinical trials to have efficacy. So I think that there's a lot of reason for excitement in this field of applying translational medicine to human brain tumors to try to come up with new subtypes that can help us predict outcome, but also take advantage of that therapeutically to come up with better treatments. So from that, I'll move to the recent study that our group looked at, which was more of a clinical study that really focused on how we treat primary brain tumors. And for this, I'll just remind you that primary brain tumors come in the benign category and the malignant category. And the four most common are 3 benign tumors: meningioma, pituitary adenoma, and vestibular schwannoma, which is a nerve sheath tumor that happens from the balance nerve that comes from the brainstem, and the most common malignant tumor, which is glioblastoma. And those 4 are the most common tumors that constitute about 3/4 of all brain tumors, primary brain tumors. And it's important that surgery is fundamental in the treatment of these when they require treatment at all. For all gliomas, surgery is usually the first step, whether it be a maximal resection or just a biopsy to understand exactly the molecular subtype of the glioma. And for these benign tumors, the three most common benign tumors, surgery is often needed for the larger ones or the ones that are growing or causing symptoms in the brain. And we were interested in studying health equality gap in surgery recommendations for brain tumors. And when you take a step back for health equity gap in surgery, there are three main contributors that may contribute to the health equity gap for cancers and tumors or healthcare more generally. And one example is factors that relate to patient level contributions to the health equity gap. And this might be, well, do patients from different socioeconomic statuses or with different types of insurance, does that influence outcomes from surgery, for example? There are also systemic levels of contributions. This would be an example of whether institutional volume contributes to surgical outcomes. And then a much harder question is to ask is how provider level, so surgery or other healthcare providers might have biases that contribute to the health equity gap. So the way we wanted to study this was to take a database approach. So our hypothesis was that inequities exist in the initial management of tumors, and we wanted to take a database approach using nationally available databases like SEER, check a primary outcome. And our primary interest was in whether patients were recommended for surgery or not, and whether we could find variables that could influence this recommendation by surgeons. And we looked at the four most common tumors in adults, which again are three benign tumors, meningiomas, adenomas, and vestibular schwannomas, and the most common malignant tumor, glioblastomas, just to increase the number of patients that we had in our data set. And that's shown here in SEER, over 10,000 to 60,000 patients in each of these groups, and the percentages of how many patients were recommended for surgery. You'll see for or recommended against surgery. You'll see for malignant tumors, that percentage is lower as one would expect. And for benign tumors, many of those patients don't need surgery. And there's a higher possibility of those patients not being recommended for surgery across the board. But we wanted to look at other demographic contributors to this recommendation for surgery by surgeons. And encoded in these databases is not just whether patients have what their age is, what their gender is, what their race or ethnicity is, but it also includes aspects of the type of tumor, the site of the tumor, the size of the tumor, and the grade, grade 1, 2, or 3. And we wanted to look at which variables were contributing the most to whether a surgeon is going to recommend surgery or not for these patients. And to make a long story short, what we found is that if we looked at each of the four types of tumors, the most common tumors, and looked at the recommendation against surgery in each of these different race and ethnicities, we found that across the board, Black race was associated with a recommendation against surgery at a higher proportion than the other races. And it wasn't in just one of the tumor types, for example, meningioma, it was in all four of the top primary tumors. And that was just using one database called SEER, but there are other national databases. So if we wanted to, what we really wanted to do is make sure that what we were finding in one database could be translated and is broadly applicable to and more generalizable. So for this, we used a different national database called the NCDB, which has an even greater number of patients contained in the database, with numbers shown here, at least 30,000 to over 200,000 patients, depending on the diagnosis. We looked at the same variables because that's also encoded in this national database, but we also had the opportunity to look at other variables that may contribute to the signal that we see, including comorbidities, and that's encoded in this score down at the bottom. So we could look at patients that have higher comorbidities, which get a higher score, versus those that had less. And we wanted to ask, well, in this new database with more patients, do we still see the same trend of Black race getting a recommendation against surgery at higher proportions than the other races? And again, what we saw was the same trend in this new database after accounting for comorbidity. So that was not a variable that took away this signal. So Black race in all 4 diagnoses had an increased odds of recommendation against surgery. So we also wanted to look at other potential confounders, such as insurance status, or whether patients were more in a rural or urban environment as a proxy for access to high volume or low volume academic centers, and look at these various areas of disparities. And to make, again, a long story short, when we took a look at all of these variables, whether patients were near a large academic center or not, and other aspects of the socioeconomic status, as well as looking at just the most recent decade to see if things were changing over time, we again found, that Black race here is associated with increased odds of recommendation against surgery in all of these subcategories, with one exception, which is glioblastoma in the most recent decade. So potentially making some progress in the most recent decade in terms of surgical recommendations for glioblastoma patients. So what this study does is contribute a little bit of knowledge to what others have shown in other aspects of the health equity gap, to understand other contributions to disparities in neurosurgery. I'd like to just highlight a couple members of our team, including Jack Butterfield, a former medical student who really led that clinical study, and a faculty member here, Aaron Marcotte, who is in the epidemiology and brain tumor program here, who helped us on the database analysis and work there. So I'll pause there, and I'll thank you for your attention. I'm happy to take questions.
Dr. Venteicher, thank you so much for providing such a thorough overview of brain tumors and shedding light on glioblastoma today. Also, your dedication to advancing research and addressing the treatment disparities in brain tumors is commendable. So thank you for all of your work. So we will now transition to the Q&A portion of our program today. And as per usual, it's not a fireside chat without getting our fire started. So we'll start kicking things off with some of the questions that we got. We have had a flood of questions. So unfortunately, I don't think we're not going to be able to get through all of them today, but I'll kind of just start asking some of the main ones that have come up so far. So to start, a few questions have been submitted about just, if glioblastoma has a genetic component to it, and if so, are there specific tests or things that you should be doing to reduce your risk, and what should you be looking for, and what should you be talking to your primary care provider about?
It cut out in the beginning. Could you ask that? I'm sorry about that.
Looks like my connection might be unstable. I'm going to just turn off my camera. I muted myself, but not my camera. Sorry about that. Can you hear me now?
Yes.
So I was saying that there have been quite a few questions submitted about if glioblastoma has a genetic component to it. So is it hereditary, and kind of what can folks do to reduce the risk?
Yeah, so in rare cases, there are familial predispositions to it. We don't think that contributes largely, although research is still being done on that. It's a work in progress, but most we think arise spontaneously. There are rare associations with radiation exposure, et cetera, but I think the overwhelming majority just we think arise spontaneously. In terms of prevention, there isn't a great clear avenue towards prevention of gliomas. And I know a common question is kind of what type of diet or exercise can I do to help lower my risk or increase my ability to withstand treatments for gliomas. And I think what you'll get most advice telling you is to just stay active, and patients do well when they are, having a balanced diet and getting exercise and maintaining activity levels. That just helps in a very general way to maintain health and activity. That gets people through treatments as best as possible.
Thank you. And I know Dr. Venteicher will need to run pretty soon here because he's also a physician and sees patients. So we'll just ask you about 1 to 2 more questions, if that's okay. And then we'll let you go save patients' lives. But there were some more questions asked about just if you have any idea why there are such gender differences seen in primary tumor malignancies.
That's a great question. So there's been some thought that, for example, meningiomas may occur more in women because they express certain hormone receptors like estrogen receptor or progesterone receptor, and that may contribute in some way. So there's been some thought that that is how gender may influence that. Why males, for example, may be more predisposed slightly to getting the malignant tumors and the gliomas. That's less clear, although there's a lot of interesting groups really focused on that question. I think the data are still upcoming.
Thank you for that. And one last question, just about the research that you presented. Has this research sparked any discussions or changes within the University of Minnesota or other healthcare institutions? If so, what are some of the key developments that you've noticed?
Sorry, cut out one more. Can you say that one more time?
Sorry about that. So has your research sparked any discussions or changes within the University of Minnesota or other healthcare institutions? If so, what are some of the key developments that you noticed? And specifically the last publication that you shared about the racial disparities that we see in surgical recommendations.
Yeah, I think we've begun discussions on how to pursue next line avenues of investigation, including collaborations with folks here and at other places. I think the first thing to understand is just what is contributing to what we're seeing in the data before we kind of design an intervention to address it. We really want to understand what's going on, to understand the major contributors. I'd say that that's kind of the biggest level that we're at right now. I would say that there are things that are happening that I believe will lessen the effect of certain socioeconomic statuses or race or ethnicity or other things to perhaps contributions to any biases that might exist. And that includes things like protocolized care. Like there's a nuanced statement I made, but in glioblastoma in the most recent decade, we didn't see this association between risk and the recommendation for surgery that we saw in all the other tumors in all the other years. And perhaps part of the reason for that is because of the study that I showed where the standard of care for glioblastoma had been established. Like everyone with a glioblastoma should get some sort of surgery, whether it be maximal resection or at least a biopsy, followed by chemotherapy and radiation. And I think that streamlines our approach to treat these, so everyone, independent of any demographic factors, would get the same treatment. So I think that's one way in which kind of we synthesize a molecular understanding for these tumors and influence a more protocolized treatment strategy that's independent of a patient's background.
Great, thank you so much. So Dr. Venteicher, will let you go here. I know you're getting paid, so we just want to express our gratitude for you, just for joining our Fireside Chat today and sharing your valuable insights and research with us all. So you can actually hop off, and we have some little end of session information that I'll share. But thank you so much again, and hope you have a wonderful rest of your day.
Thank you very much for having me.
Bye now.
Bye-bye.